Today, the title of my talk is Driving Dirt Road Equity, Reimagining Rural Health. And just to get us started today, I wanted to share a little bit about my background and the perspective that I bring to this conversation. I am a public health practitioner, researcher, and educator. I work at the intersection of public health, public policy, and anthropology. I primarily do community-based, action-oriented, policy-engaged research, and I've had the opportunity to work across a lot of sectors over the course of the pandemic through my work and to collaborate with many others in the policy space, both in Vermont and across the country. My research has focused on COVID-19 and rural health equity in northern New England, and I'm a rural Vermont resident. I live, work, and raised my family in a rural Vermont community. I do not have anything to disclose. In May 2020, as the US was emerging from the first devastating wave of the coronavirus pandemic, the New York Times headline read, US deaths near 100,000, an incalculable loss. Nearly 3 years into the pandemic, the US has surpassed 1 million deaths and continues to register nearly the equivalent of a 9/11 attack almost every week. What is 10 times incalculable? Journalist Ed Young of The Atlantic asked earlier this year in a piece exploring how the US had normalized such a high death toll. But what's striking is not simply the magnitude of this loss, but rather the sharp gradient of it. The US has seen large and enduring disparities and impacts. Surge after surge has disproportionately impacted communities of color. More than 200,000 American children have lost caregivers, and for the first phase of the pandemic, Black children were twice as likely and Indigenous children 5 times more likely to lose their caregivers. Life expectancy in the US has fallen by 2 years and by nearly 7 years in Indigenous communities. Communities came into the pandemic on very uneven footing, have experienced the pandemic in very different ways, and look to the future on different footing. Poor outcomes have accumulated at the margins and not at the medians of our society. Essential workers, underprotected by policies and workplaces, suffered grossly elevated infection and death rates. Most workers who died during the first year of the pandemic were in their essential workforce, and low-income workers have continued to register greater health and economic impacts. Nursing homes, long neglected by our society, were the site of devastating and deadly outbreaks. In New Hampshire, 80% of deaths in the first phase, the highest in the country, occurred in nursing homes. Prisons were not only home to large and deadly outbreaks, but also acted as epidemic engines in their communities. Disabled Americans were infected and died in disproportionate numbers. Immunocompromised people have been overrepresented in hospitalizations and death and continue to be at elevated and by some measures increasing risk as non-pharmaceutical interventions evaporate and our arsenal of clinical tools shrinks. Poor outcomes have also accumulated at the geographic margins. Once seen as a haven from the pandemic, rural communities have outpaced urban ones in deaths since summer 2020. The pandemic has also taken a heavy toll on our rural health systems and the healthcare workers and public health workers that have toiled on the front lines. And while the pandemic has shifted from urban centers to rural regions, its impacts have not been borne equally by rural residents. At the peak of the Omicron wave, Black rural residents died at a rate that was 34% higher than white rural residents. Available data points to large disparities by income that persist across urban and rural lines. As I wrote recently with the leader of a patient advocacy group, available data also suggests that rural regions will leave with a greater burden of disability from long COVID, but fewer resources to address it. Northern New England has outperformed the rest of the country in its COVID response. However, it is not immune from the disparities that we see elsewhere. Rural counties in the larger New England region surpassed urban counties in summer 2021 in deaths, and counties with greater social vulnerability have seen higher death rates. What explains these disparities in rural communities? And more importantly, how can they inform our health work beyond the pandemic? As the pandemic has worn on, two schools of thought have emerged. The first is that rural people have made bad choices that have led them to die in disproportionate numbers. And this school of thought maps very nicely onto voting behavior and to other accounts that we hear frequently of rural America. The second school of thought believes that rural communities came into the pandemic facing systematic disadvantages that have structured their exposure to the virus, shaped and constrained their health choices in adverse ways, and left them less protected when they did fall sick. And while most agree that the former presidential administration grossly mismanaged the pandemic and that we have consistent data showing differences in COVID outcomes across partisan lines, particularly in rural areas, this explanation, I'll argue, distracts from many of the long-standing structural problems and inequities that predated the rise of Trump and Trumpism and laid the groundwork for this crisis. Rural disparities, I will argue, reflect the intersection of individual choices that are shaped by collective norms and institutions. These disparities are driven by structural forces and not simply individual choices. They reflect differences in exposure and transmission patterns, some of which are distinct to rural areas. And these disparities are shaped by differences in underlying public health and healthcare infrastructure. But more importantly, I will also argue that they're not immutable. As a foundation for our conversation today, I want to lay out two definitions that I commonly employ when I'm thinking about health equity, and I've heard many others today. And this is meant to complement those other definitions. The first, from the Robert Wood Johnson Foundation, defines health equity as fair and just opportunity to health and encompasses a broad range of other factors, including poverty, discrimination, and the social and economic determinants of health. The second, from a 2006 WHO paper led by Margaret Whitehead, distinguishes inequities in health from differences as those that are systemic, socially produced, and therefore modifiable and unfair. I want to quickly map these definitions of health equity onto a rural context in the context of COVID. When most of us think about risk to COVID, we think about underlying health status at an individual or population level. We all know that people with underlying health conditions are at higher risk of COVID and that vaccination and other biomedical interventions can reduce risk. We also know that access to healthcare shapes health outcomes. But vulnerability to COVID also reflects exposure and transmission patterns. And these exposure and transmission patterns are largely shaped by social factors, including occupation, living conditions, and transportation. COVID disparities reflect the convergence of disproportionate medical and social risks, both in terms of structural and individual and population level. This in part explains why we saw such devastating outcomes in long-term care facilities and communities with a high concentration of multi-generational households, both of which often bring together medically high-risk people with highly mobile, low-income workforce with inadequate social protections. A dual narrative emerged early in the pandemic that rurality is protective and rural institutions are fragile. Anthropologists Thurka Sangomorty and Adia Benton describe this tendency to see rural regions as less vulnerable to COVID as the imagined immunity of rural America. Others have pointed to the rurality of northern New England to explain its early performance during the pandemic. This focus, however, on physical distance between individuals and homes ignores the structural and geographic factors that shape collective COVID risks. Prisons have been a growth industry in rural communities, even as they have declined sharply in rural communities. Meatpacking plants are also disproportionately located in rural regions. These epidemic engines have not only been the sites of large and deadly outbreaks, but have also driven growth of COVID within rural communities. Our northern New England region relies on common commercial centers and anchor institutions that draw together a highly mobile essential workforce from a large geographic area. Many workers in high-risk workplaces share households. Dual employment is common among workers at long-term care facilities in the region, a setting that was very hard hit in the first phase of the pandemic. Rural regions have also seen an accelerating loss of healthcare infrastructure. Rural areas across the US have hemorrhaged hospitals, pharmacies, primary care practices, and healthcare providers. 2019 was the worst year for hospital closures. Dr. Jan Probst, a rural health scholar at the University of Southern Carolina, and colleagues described the geographic inequities in the distribution of healthcare infrastructure and resources as a form of structural urbanism. They define structural urbanism as a bias towards large population centers that results from a focus on individuals and infrastructure in the design of both healthcare and public health policies and interventions. They argue that rural disparities in part reflect the cumulative effect of policy choices and processes that have systematically disadvantaged rural communities. A narrative has taken hold that public health has failed the US, and I want to argue instead that the US has failed public health for a long time, and nowhere have these failures been more apparent than in rural regions. Decades of disinvestment have left public health agencies and entities with threadbare staff, insufficient infrastructure, and limited elastic capacity to respond to crises. Political concerns have frequently prevailed over public health in the decision of policymakers. Public health leaders have often had limited influence on policies made by political leaders and their appointees, but have absorbed political backlash, fragmentation, corrosion of trust, and the added work burden that resulted from them. Many states have rejected public health funding for political reasons, and these challenges were especially great in rural regions and have contributed to widespread burnout and moral distress among the public health workforce. I know that many of you have experienced these challenges firsthand. In part as a result of these increasing geographic inequities in the distribution of public health and healthcare resources, rural regions came into the pandemic in poor health. Rural disparities in age-adjusted mortality rates grew in the 2 decades preceding the pandemic. While 1 in 4 Americans has a disability, 1 in 3 in rural regions do, in part reflecting the age structure of the population. Rural Americans also have a higher prevalence of multiple health conditions and face a greater risk of mortality from heart disease, cancer, chronic lower respiratory disease, and stroke. And this chronic constriction of public health and healthcare is also the backdrop for many of the individual level decisions that culminated in poor health outcomes. An overwhelming majority of rural residents cite their healthcare providers as their most trusted source of COVID-19 vaccine advice. Less than a majority cite Fox News or social media as their most trusted source of information. Yet we know that many in rural America have had more ready access to a steady stream of misinformation from these sources than from healthcare providers. Disadvantages compounds and concentrates, and COVID tools have also not been equally distributed. In many rural communities, vaccination, booster testing, and now test to treat sites have been fewer and further away, adding to the challenge of protecting oneself. And this meant that even though you were more likely to get severely ill if you contracted COVID in a rural community, testing and treatment sites were often more difficult to access. And if you were severely ill, you faced an uphill battle getting a hospital bed. And if you were a rural patient needing a transfer for COVID or other conditions, as academic centers came under enormous pressure, it was harder to access tertiary care. And yet, despite the significant disadvantage that many rural communities faced, they were often where the US's individual and collective empathy went to die. Deficit narratives around rural America have long abounded. I am sure that many of you who, like me, live and work in a rural community see these deficit narratives reflected in disparaging representations from urban residents, as well as internalized by rural residents. We hear that rural communities lag behind urban ones, that rural residents should just move to urban places, and that their poor health is their fault. This urban bias is also reflected in the erasure of the strengths of rural places that include close-knit communities with dense social networks and high levels of local civic engagement. These narratives have been harmful for many reasons during the pandemic. They normalize rural disparities, erode the will to act in response to them, and individualize the failure of systems and policies. As the pandemic has accelerated, these pervasive deficit narratives were amplified and used to argue that some should be denied care or support. Rural is not a monolith, and Northern New England is not the rural South or the Midwest. That said, we do see urban-rural disparities on a regional and local level that have shaped our experience of the pandemic and the challenges we've seen over the last 3 years. While our Northern New England region leads on many top-line indicators for health and well-being, closer examination reveals regional and local disparities in both opportunity and outcomes. In many parts of the region, we see the proximity of poverty and prosperity. And sometimes geography, small population size, and local differences can make it even difficult for us to think about health equity across the region or within our own communities. And when we look beyond state level indicators, we see local disparities in health outcomes, including life expectancy. Northern New England has not witnessed the same loss of rural hospitals and healthcare infrastructure as many other parts of the countries, but its rural health systems also entered the pandemic facing significant workforce, fiscal, and capacity challenges. Vermont had the lowest ICU beds per capita at the start of the pandemic, and New Hampshire was 8th and Maine 12th. Healthcare resources and critical care capacity concentrate at academic medical centers and more densely populated areas. Primary care shortages are large and growing as many across the region retire. Public health has also been inadequately funded and resourced, particularly in the state of New Hampshire. Vermont has consistently been the most vaccinated state in the US across all age groups, and Northern New England is far more vaccinated as a region than the rest of the country. Yet again, these top-line indicators obscure local disparities in vaccination that mirror other social and health disparities and concentrate in areas with less resources. And it was this overlay of low vaccination rates, populations that are a higher risk of COVID-19, and social disparities that created the conditions for the region's acute pandemic challenges and will also affect the landscape moving forward. Local pockets of vaccination that concentrated around rural hospitals and a rural health ecosystem with limited elastic capacity laid the groundwork for the challenges that the region confronted during the Delta and Omicron surges over the last year. The region's hospitals saw many days at capacity, and access to care for COVID and non-COVID patients served by critical access and community hospitals was severely constrained. The crisis amplified differential access for remote rural patients served by our regional health systems. And I want to highlight that this differential impact on access to care for more rural patients represents a concern for rural health equity that needs to be both anticipated and addressed in the context of crises. And yet that's not the whole story, and probably not the most important one in our Northern New England region. Despite these many underlying challenges, our research on COVID-19 and rural health equity in Northern New England has consistently documented efforts that reflected tremendous strengths in the rural responses to the pandemic on the part of rural health systems, social service organizations, and communities. Health systems made lists of their highest risk patients and dispatched community health workers to support them. Health systems served as trusted messengers within their own communities, and communities mobilized and formed mutual aid groups to support health systems and community members. Absent vaccines, treatments, or tools, communities turned inward and relied on networks, coalitions, and trust developed from both routine community work and responses to other crises such as Hurricane Irene. And this early response, characterized by what we have described as a rural ethos, for a constellation of compassion, pragmatism, and solidarity in many ways contrast with both American individual and institutional tendencies towards individualism. We saw collective and community action sustained long beyond what occurred in many places. Trust, now this demonstrated empirically to be a key element in predicting pandemic performance, was critical, especially at a moment when resources were scarce and our understanding of the virus and how to control it were rapidly evolving. And while this village versus virus ethos doesn't substitute for equitable or effective policies or public health interventions, we'll argue it's in part what animates them. We have also seen firsthand that policy choices and not simply individual action matter in shaping the trajectory of the pandemic. Much attention has been focused over the last 3 years on public health measures. We've also seen the unprecedented use of social policy for public health purposes, including eviction moratoriums, use of non-congregate shelters, decarceration of prisons, use of temporary sick leave, the child tax credit, and waivers on the use of telehealth. The use of many of these policy approaches was critically important to averting many of the devastating outcomes we saw in other settings. The pandemic also created natural policy experiments and added to a very large body of existing evidence on the use of policies to address the social determinants of health. And much of the effective work that has been done here also reflects an intention to the specific needs of rural populations. Groups that were perceived to be at higher risk were often prioritized in the northern New England region. Responses were designed specifically around here. And I want to briefly highlight the work of the North Country Public Health Network, which early on recognized the enormous transportation barriers that a small number of mass vaccination sites would pose, and defined several practical strategies to close these geographic gaps in access to vaccination. And we documented similar attempts to address the very specific needs of groups that were perceived to be at risk or face additional barriers to care or protection throughout the first phase of the pandemic. To bring all of this together, rural COVID inequities are driven by structural forces and not simply individual choices. They reflect the underinvestment in public health and healthcare and are shaped by policy choices and processes that over time have disadvantaged rural communities. Geographic disadvantages, including distance and access to specialty care, are amplified by the pandemic. At the same time, they are generated by policies and systems that go far beyond the health sector, including housing, transportation, and criminal justice. Rural COVID inequities are upheld or normalized by narratives that normalize rural disparities. Yet the outcomes that we see are amenable to policies, this attention to the specific needs of rural populations and local action. So the real question I want to ask today, though, is how do we alter the trajectory of rural communities as well as those rural residents who experience disparities within them? How can we leverage lessons from the pandemic to make headway on other long-standing challenges confronting rural communities in our region? To do this, I want to propose a 10-part framework for how the pandemic can help us to reimagine rural health equity. Lesson 1, rural health equity is health equity. We need to first assert that rural health equity is health equity. Rural communities, as well as groups within them, face disadvantages that are systematic and socially produced. Rural equity should be considered in broader decisions around how care is allocated, interventions are designed, and other policy decisions that affect health are made. We also need to be intersectional in our thinking. Rurality and place-based disadvantage intersects with other forces, including structural racism, ableism, gender-based discrimination, to generate health disparities in rural places. Lesson 2, rural COVID disparities must orient our investments and not simply our outrage. Gaps in rural vaccination, as well as access to other tools, concentrate in areas with greater rural disadvantage. We need to prioritize these areas for investment in health, education, and economic opportunity. Many of the structural drivers that have shaped COVID disparities, working and living conditions, high rates of incarceration in rural communities, and the inequitable distribution of care also contribute to non-COVID disparities. We did not need a pandemic, for example, to tell us that crowded housing conditions and housing instability fuel a broad range of other health concerns. However, it should guide our investment beyond the pandemic. The third lesson is that policy choices matter. The Herculean efforts that we have seen across our region have often taken place against a background of scarcity that reflects decades of underinvestment in public health and healthcare, education, housing, and community well-being. While these efforts have played a critical short-term role in meeting needs at an individual level, they do not alter the collective trajectory of health in rural communities. They do not address the region's large and growing crisis of affordable housing, living wages, loss of healthcare, and educational infrastructure. Reversing rural disadvantage will require policy action around health and other sectors that shape the social determinants of health. And to echo Betsy's earlier point, we should see this as a call to bring our public health and health equity voices to these other important policy conversations. And 4, evidence for policy action. The pandemic has added to a large body of evidence that specific policies can mitigate COVID disparities, but also they can address other longstanding health challenges. We now have several studies showing that housing protection, including eviction moratoriums and the use of non-congregate shelter, not only averted the worst COVID outcomes, but also had non-COVID health benefits. A recent paper in Health Affairs showed higher vaccination coverage in cities with paid sick leave. We also have growing evidence around the benefits of the use of the child tax credit. As we look forward, we need to focus on how to translate this added evidence into policy changes. Lesson 5, ensure rural equity in design and implementation. Prioritizing high-risk individuals and impacted communities is the fastest path to equity, given that we know that poor outcomes do not distribute equally. The pandemic has highlighted the importance of centering equity in the design and implementation in every program and policy in public health, healthcare, and other sectors. Instead of thinking as equity is something we will get to or a standalone set of activities, we need to ensure that it is intended to in the design and implementation of everything that we do. This demands specificity in terms of the groups that may be disadvantaged, the mechanisms that produce these disadvantages, and the measures that may remediate them. Lesson 6, look health beyond the health sector. Over the course of the pandemic, we've seen other sectors emerge as key actors in the public health response, and we've seen the intersection of many public health and education, housing, and many other areas. Schools have emerged as key actors in the public health response, and we've come to understand that public health is fundamental to action. We have also seen the intersection of public health, criminal justice, housing, labor, transportation, and many other areas. As we look beyond the pandemic, we have an opportunity and imperative to build on these intersections and alliances across sectors to address other critical health challenges. In my own work, I've often sought to partner with others from beyond the health sector, including housing organizations, legal aid, and educators, to bring expertise and evidence bases together and to model collaboration across sectors. Lesson 7, rural institutions matter. Our critical access in community hospitals, FQHCs, and other rural institutions mobilize quickly and effectively to create clinical capacity and support the public health response in their communities. As trusted anchor institutions, They often effectively bridged between the healthcare system and local communities. Importantly, these rural healthcare providers often were the only places that many in rural communities could access care. Preserving and supporting these institutions is fundamental to ensuring equitable access to care. Village vitality. When we talk about rural health, we often hear the descriptors that rural is older, sicker, and poorer. For this reason, the COVID conversation in rural spaces is often centered on older adults. Yet we know that younger people play an enormous role in driving the transmission of COVID within their communities, and that young people have sustained health, educational, and social impacts throughout the pandemic. We also, when we look beyond the pandemic, we see that many of the most pronounced rural health disparities occur not in late in life, but at midlife. Northern New England saw the largest relative increases in midlife mortality prior to the pandemic, owing largely to what scholars have described as a rise in deaths of despair. Rural health equity needs to see itself focused on closing gaps in both opportunities and outcomes across the lifespan. Lesson 9, irrigate empathy deserts. Irrigating empathy deserts and rehumanizing rural narratives is central to our work to advancing rural health equity. Harmful narratives do not alone shape policy or drive inequities. However, unchecked, they underlie inaction and tacit acceptance of the inevitability of poor health outcomes and disparities. We need to use our collective voices to drive new narratives and generate empathy for rural people and stigmatized groups within rural places. We can highlight the strengths within rural health systems and communities, situate the challenges that we see against the larger backdrop of rural disadvantage, and share evidence showing that it is possible to make progress on many of these challenges. This is a responsibility that we all bear within the space. Finally, lesson 10, disrupting narratives of inevitability. The pandemic has taught us that our actions can change the trajectory of health in our rural communities. We have not only seen that the use of unprecedented policy, such as the use of housing protections as a tool for public health, paid sick leave, expansion of telehealth, the child tax credit are possible, but then also that when we use them, we see health and social benefits. We now have a mounting body of evidence to support these interventions that adds to what we already knew. Poor outcomes are not inevitable. The evidence in our experience has shown us they are a policy choice that we make together. They reflect our collective action in communities. At the same time, we've seen that local communities and actors can close gaps in access to healthcare, protect one another, and respond quickly in the face of a crisis. We also know that the proximity to the policy process at the state and local levels that's afforded to us by our rural environment gives us greater opportunity to advance health equity through the policy process. I want to conclude by saying that our Northern New England region has shown that vast disparities in rural outcomes are neither inevitable nor immutable. The partnerships we build, the initiatives we design, and the policies we collectively choose matter. Let's team up, take action to drive rural health equity.